This conference will now be recorded.
So my screen is visible to you? Is the screen visible?
Yes, sir.
Okay, so now continuing from last time where we finished off last time, we had talked about the surgical anatomy and a few of the diseases and the physiological conditions and pathological conditions like hypersplenism and hyposplenism last time. Now, taking it forward from there, coming to the most important part for we as surgeons is the splenomegaly, when we identify or when we palpate the spleen in a surgical patient. And we have to know the etiology of the uh, splenomegaly. Was the reason why the spleen is enlarged in a particular patient. Now, you can divide them in a number of ways. Uh, could be clinical methods of identifying splenomegaly, clinical help, or you can have a ecological classification. First, let's talk about the ecological classification. So the first group of conditions will be those which are not directly splenic in origin, but the spleen is getting secondarily involved. Like, for example, liver diseases. Most commonly, we find a splenomegaly in cirrhosis, hepatitis, portal hypertension. And in all these conditions, it's basically the parenchymal liver disease, which is affected, leading to increased sinusoidal pressures and ultimately a back pressure over the vascular compartment, leading to an increased splenic size. Then you can have a number of hematological conditions and malignancy, like, for example, leukemias, myeloproliferative disorders, neoplastic cells, they are now infiltrating the spleen. So that again is a cause for splenomegaly. Then coming to the direct causes in the spleen itself, either splenic congestion or a splenic sequestration and cytopenias because of the sequestration. So congestion commonly seen in those conditions, like, for example, secondary to congestive cardiac failure or venous thrombosis of the hepatic vein, the portal of the splenic vein thrombosis, or you can have a sequestration of the various cells, like, for example, in hemoglobinopathies like Thalassemias, sickle cell anemias, hemolytic anemias, you have purpuras, immune-mediated neutropenias, and so on and so forth. Basically, what's happening in these conditions is that there's immune-mediated destruction of RBCs, leading to white blood cells or platelets being shed off or being filtered back into the spleen, leading to a functional splenomegaly. Then you can have acute or chronic infections leading to splenomegaly. Like, for example, bacterial endocarditis, infectious mononucleosis. Even tuberculosis of the spleen is an important condition for that matter. It should be remembered. Important in the sense it should always be kept in mind. Then you have a number of connective tissue disorders, like, for example, systemic lupus erythematosus, rheumatoid arthritis, Felty syndrome, adult onset SILS, and so on and so forth. Infiltrative disease is another cause, and that is an important cause. Why? Because this is a cause for gross splenomegaly. We'll define what gross splenomegaly means in the next slide. So you have sarcoidosis, you could have amyloidosis, glycogen storage diseases, and so on and so forth. Then you have focal lesions in the spleen itself, which are primary splenic lesions. For example, you can have a hemangioma in the spleen, you can have an abscess, a cyst, or you can have a metastasis in the spleen. And then, of course, the primary neoplastic conditions of the spleen, which are related to vascular malignancies, angiomas and angiosarcomas, and to the fibrous tissue in the spleen, primary fibrosarcoma, or to the cellular component of the spleen, namely the lymphomas. So that is one method of trying to identify what is the cause, but that doesn't serve too much of a purpose as far as clinical is concerned. So clinically, what is better is a classification based on the size, and based on this, you call a spleen either minimally enlarged, a moderately enlarged, or a massively enlarged. Now, what do we mean by minimally? Minimally basically just means that you're 1 to 3 centimeters below the costal margin. It's just palpable, just palpable. And in these conditions, if you look at the long axis of the spleen, it is somewhere around 8 centimeters or less than 8 centimeters, right? When you talk about a moderate splenomegaly, you're talking about the same palpation below the costal margin to extent of 4 to 8 centimeters, but it is still to the left of the midline. It does not cross the midline still. And if you look at the largest dimension or longest axis of the spleen, it would be somewhere in the region of 11 to 20 centimeters. But once it crosses the midline, it's to the umbilicus or crosses the midline to the opposite side, or it is more than 8 centimeters below the costal margin in the largest dimension, Or if you look at the long axis, it is more than 20 centimeters. The weight is more than 1 kilogram. So in all these conditions, it is known as massive splenomegaly. And how does it help you? It basically helps you because there are definite causes for a minimal or a mild splenomegaly, for a moderately enlarged spleen, or a massively enlarged spleen. And you have the causes listed out here. I'm not going to read them out for you. You can just have a look at these causes. But it is very important because once you get an idea you got a moderate splenomegaly, then immediately a number of causes are ruled out. You don't even think about them. And a number of causes are ruled out on the opposite side. Like, for example, a massive splenomegaly cause could not be accounting for a moderate splenomegaly. Like, for example, storage diseases, sarcoidosis, primary tumors of the spleen, and so on and so forth. So this is a better clinical method of identifying a spleen. Now, when we as surgeons talk about splenomegaly, we are basically concerned, as I told you last time, the surgeon's spleen. So what do we talk about surgeon's spleen? It is basically a spleen which may require splenectomy. So what are the indications for splenectomy in a splenic pathology? One, we already talked about traumatic. Either it is a rupture because of an inadvertent trauma, or it is because of an iatrogenic trauma. You're carrying out some kind of a dissection inside the abdomen and you manage to damage the spleen. In either case, the spleen has been ruptured or traumatized, and there could be an indication of either removing it in totality or partially. So that becomes one of the very important indications for carrying out either partial or total splenectomy. The second group of conditions relate to the hematological causes. And among the hematological causes, the one which comes foremost and which is the most common cause for splenectomy is a immune thrombocytopenia, which was initially known as idiopathic thrombocytopenic purpura. That is the old name. I'll just talk about that in a couple of slides subsequent to this. Then coming to the hemolytic anemias, you can have any of the hemolytic anemias. We talk about the classification later on. So that forms another important indication for hematological condition where splenectomy may be required. Spherocytosis, non-spherocytic, hemoglobinopathies, thalassemia, sickle cell, autoimmune, acquired, and all these hemolytic anemia. Then comes the malarial causes, again grouped as a hematological. Why? Because here is the RBC and the malarial antigen which is causing the havoc and leading to splenomegaly. We'll talk about that also. Schistosomiasis, leishmaniasis, these are conditions which are pretty rare in the Indian scenario, but leishmaniasis has been identified in Eastern UP. Then this is one of the group of conditions where splenectomy is required. Then comes another indication where there is something wrong apart from spleen, but spleen has to be removed as a part of some ongoing process. Like, for example, you've got a carcinoma of the stomach, you're carrying out a radical gastrectomy. In a radical gastrectomy, there are various kinds of radical gastrectomy. We'll talk about that in one of the future lectures. Number of causal radical, number of methods of tackling gastrectomy, and number of types of radical gastrectomy. A few of them remove the spleen along with it. Similarly, distal pancreatectomy, you remove the tail of the pancreas, you may have to remove the spleen. Like, for example, lymphoma, a Hodgkin's and non-Hodgkin's lymphoma, where the spleen may be required to be removed either for a staging purpose or therapeutic purpose. Lymphoproliferative disorder, not a very common cause for splenectomy. Hairy cell leukemia, again, not a very common reason for carrying out a splenectomy. But then come the important miscellaneous condition. Like, for example, you're treating a patient with gastric varices, either cirrhotic or non-cirrhotic. You're treating a splenic artery aneurysm, or on the other hand, the other vessel, that is splenic vein thrombosis. You're treating a splenic mass, like, for example, you got a large cyst in the spleen, you got a tumor in the spleen, abscess in the spleen, or a Felty syndrome, or a Gaucher's disease, which is an infiltrative, or Niemann-Pick's disease, again infiltrative disorder. So these are all glycogen storage disorders, and of course in AIDS. So these are the indications for splenectomy. Now coming to the important ones, we'll just be dealing with them in very short. The first one, this is a very short indication chart. If you want to remember this, you can remember this. But this is, I think, a fairly easy chart to remember. Anyway, you got a choice. This is basically taken from Love and Bailey, so you can go and refer to that. This is easier to remember because there are fewer causes listed out here. Now, coming to the most important reason why a splenectomy is required after trauma, of course, and that is idiopathic thrombocytic purpura, thrombocytopenic purpura, and see the name which is written immune thrombocytopenia. Now, why the two names? Now, it was in 2009 that the ITP work group, that is idiopathic thrombocytopenic purpura, redefined ITP. Why? They dropped the term idiopathic and they dropped the term purpura. Why? For the simple reason that now most of these causes have a reason to them. Initially, it was idiopathic. We didn't know why this is occurring, but now we know why it is occurring. So they decided to drop the term idiopathic. And then why did they want to drop the term purpura? Because the majority of these patients who have been grouped as ITP, they never present with any clinical symptoms of purpura. And that is why the new term, which is now being substituted for ITP, is an immune thrombocytopenia or autoimmune thrombocytopenia, right? And this immune thrombocytopenia is now classified under two groups. One, which is idiopathic, where we still don't know the name, which is what we were talking about initially, primary ITP or primary TP. We'll like to call it a primary TP. That is a primary immune thrombocytopenia, or secondary, where we now know the cause. A number of causes are known, like example, infections, rheumatological conditions, SLE, CLL, that's chronic lymphoid or lymphoblastic leukemia, or Hodgkin's disease, etc. So these are all those conditions where there is an immune thrombocytopenia. But let's focus on the primary ITP or primary immune thrombocytopenia. Now, when you talk about the primary immune thrombocytopenia, the definition entails three important prerequisites. Number one, that there should be an isolated thrombocytopenia, which is less than 100 into 10 to the power 9 per liter, or 1.5 to 4.5 lakhs per cubic millimeter. Number two, the bone marrow should be absolutely normal. And number three, there should be no other cause of thrombocytopenia. Only then you like to call it a ITP. So three important parts to definition. Isolated thrombocytopenia. Why do we say isolated? Isolated here refers to the term that there is no RBC deficient, there is no WBC deficient. That means there is no neutropenia, there is no decrease in the red cell mass. It's only the thrombocytopenia which is basically at fault. So normal bone marrow, and number three, no other cause of thrombocytopenia. What is the pathophysiology? In simple terms, pathophysiology is nothing but there is an antigen antibody reaction or combination on the surface of the platelet. You've got circulating IgG antibodies which are basically acting as the platelet membrane glycoprotein, which is the antigen on the surface. They code these antigens, leading to what? Splenic sequestration and phagocytosis of these platelets by the macrophages in the red pulp. Remember the red pulp we talked about last time? So these coated platelets, coated means in the sense where the surface antigen has been coated by a circulating antibody. So these now become pathological. The macrophage removes it. So that leads to what? Shortening of the lifespan of the platelets in circulation. That's number one. Number two, at the same time, what else is happening is that the megakaryocytes lying inside the bone marrow are not adequately, they're not adequately compensating the fall in the platelet level by increased production. And in addition to that, there is a dysfunction of the megakaryocyte. So one, their function as far as production is concerned, and number two, their function as far as the qualitative function is concerned at the megakaryocyte level, both of them are being defective. And that ultimately results to what? A decreased number of circulating platelets. So ultimately what we're talking about is the thrombocytopenia, right? Now, based on the chronicity, you have a number of subtypes. Like example, a newly diagnosed that is identified within the last 3 months, or persistent that this patient has been having the disease for the last 3 to 12 months, or chronic once the disease process has been there for greater than 12 months. The second group is the clinical presentation subtype, where it can present either as an acute or it can present as a chronic. Acute is usually in children less than 5 years in age, and spontaneous resolution in 2 months. The chronic is usually found in the adult type, mostly females, 15 to 50 years of age, and present for more than 12 months. So basically what we are doing is we are trying to classify the immune thrombocytopenia into two groups. Number one, a number of groups based on chronicity, that means the duration of the disease, and number two, the pattern of appearance of the disease, whether it appeared as an acute phenomena initially or the chronic phenomena initially. The third method of trying to define ITP would be based on the age pattern. It is a child or a younger age group ITP or immune thrombocytopenia, or it is an adult variety. Now, why the need to do this? Because the children ITP or children IT is spontaneously remitting in almost 75%, right? 75% time it remits, almost up to 83, and there's a recovery rate of almost 90%. That means spontaneous remission is 75 to 83, and the further with treatment more remit, so it comes somewhere in the region of 90%. Usually it's always an acute presentation, and the recovery time or the spontaneous remission time is usually about 4 to 8 weeks, that which basically means 2 months, and more than 50% of them would recover in 2 months. The rest will recover after excuse me, some more time. The mortality is very low, approximately 2%. On the other hand, contrast this with the adult type of ITP, where the spontaneous remission is only 2%. Here it was about 80%. Here it's only 2%. And eventual recovery, although is there closer to this, 90% and 64%. That means this is spontaneous, this is induced after some therapy. Usually presents as a chronic disease, and mortality is also more. Here is 2%, here is 5%, and the mortality is usually because of intracranial hemorrhage. So what are the signs and symptoms of ITP or thrombocytopenia purpura? And that is childhood ITP is typically abrupt. We just now told you that. Adults gradual. How does it present? Number of post pressure or post traumatic bruising. You can find these bruisings over the skin surface. You can have petechial hemorrhages. You can have spontaneous bleeding from the mucosa in the form of epistaxis, gingival bleed. You can have menorrhagia in females. You can have wound bleeds which are prolonging themselves. You have no reason why bleeding is occurring in a particular wound. And rarely these patients can present with either GIT bleed, urinary tract bleed, or even hemarthrosis, like similar to hemolytic anemia, or intracranial hemorrhage, which is rare, but then it is a primary cause for death in ITP, although it is rare, right? So how do you diagnose this condition? Number one, petechial hemorrhages are very much there. Can you induce them? That is what is known as the Tunica Test. You do nothing, just inflate the cuff midpoint between your systolic and diastolic. So if it's, let's say 120/80 is your blood pressure, so midway is 100. So the cuff will be inflated to 100, leave it there for about 5 minutes, and then reduce the pressure for the 2 minutes, and subsequent to that, count the number of petechias over the antecubital fossa. If it's anything more than 10 per square inch, it is a positive test. That is the Tunica test for thrombocytopenic, for idiopathic thrombocytopenic purpura, or what we know as immune thrombocytopenia. Spleen is palpable less than 10%. Look, that is very important, because you may either find a very mild splenomegaly or no splenomegaly at all. ITP never gives rise to any moderate or massive splenomegaly. It is either no spleen or minimally enlarged spleen. If you look at the investigations, you'll find an isolated low platelet count. Why isolated? Remember, that is part of the definition. If you have anemia or neutropenia, be sure that you have some other disease, not ITP. Is that clear? That is a very, very important part of the definition. Bone marrow will show high levels of megakaryocytes. Antiplatelet antibodies, antinuclear antibodies could be found, but then they are non-specific. So apart from these three findings, in diagnosis, you don't find anything else. Bleeding time is not helpful. A coagulation profile is not helpful. The bottom line as far as treatment is concerned is there is no cure known. You just have to increase the platelet count to safe level. Now, what is a safe level is a very, very debatable. In a surgical patient, if you're the patient is going to undergo any kind of major surgery, 50,000. Minor surgery, spontaneous bleeding, 20,000. Right? Instead of 1.5 lakhs, it is 50,000 or 20,000. So any major surgery has to be above 50,000 or 80,000, and spontaneous bleeding starts occurring below 20,000. So that is how you calculate, that is how you look at the safe level. Now, when you have a presentation of acute ITP, you usually do not require treatment. If it is a child, you usually do not require treatment, while 75% of them would be spontaneously regressive. But if you have a dangerous platelet count level, I just not told you what it means, or the patient is symptomatic, irrespective whether it's a child or it's an acute presentation, symptoms are there, then you have to treat this patient. Now, if the count is, so basically when you're trying to treat a patient of purpura, you're looking at two things. Number one, the platelet symptoms I just not told you. Now, if you look at the first one, and that is the platelet count, and you're talking about 30 to 50,000 per cubic millimeter and no symptoms. Remember, no symptom. So invasive procedure safe, no treatment required, observation and follow-up. But 30 to 50,000 with symptoms, or 30 to 50,000 in a high-risk patient, like for example a patient of hypertension, or less than 30%, 30,000 count. So this is a very important group where you would require treatment. And what is the treatment which you would assign to this patient? Steroids are the mainstay of initial management of any acute ITP, especially in the setting of a life-threatening thrombocytopenia or an urgent or emergent elevation of platelet count required. Like for example, let's say a patient of ITP comes to you with strangulated hernia. Now you have to operate on this patient. Why? You can't leave a strangulated hernia just like that. This patient is going to go into gangrene, would develop gangrene of the bowel and going to land into septic shock. So you have to treat this patient and you require an urgent elevation. So these are the, this is a group of condition, group of patients we require steroid therapy. So how do the steroids work? Number one, they reduce the rate of platelet destruction. That means the antigen antibody reaction occurring on the surface of platelet and then getting filtered out by the macrophage and phagocytosis of the macrophage activity, that is reduced by the steroids. And number two, it also alters the endothelial cell integrity of the cells inside the spleen, facilitating primary hemostasis and reduces the bleeding and bruising all over the body, right? The dose that is required, usually which drug would you prefer? Either oral prednisolone or dexamethasone as an IV. The dose is a short course, 1 milligram per kilogram per day of prednisolone. I've given the doses out here. Just read it up. Prolonged use is not indicated. Remember one thing: if you're using steroids, it's not that you start steroid today and you forget about it, keep it on for 1 year. Patient comes back every month. You say continue, continue, continue. That's not to be done. So it is not to be given on a long-term basis. Number two, platelet levels of more than 50,000 should be expected after your steroid therapy within a span of 1 to 3 weeks in 2/3 of the patient. But that's a long time. That's a long time, right? So you may require a more urgent and an emergent elevation. We'll just talk about that in the next slide. Complete response with steroid therapy is seen in 25% patients. In the rest of them, it is a partial response. The other group of patient is a patient who is much more serious or much more graver ITP disease or IT disease as compared to the first patient, who was being treated as an OPD patient. Now here this is a patient who has got a platelet count persistently below 20,000. I told you the cutoff level for spontaneous bleeding. Persistent or life-threatening bleed. Pregnant females. Emergency surgery required, I just now told you, and preoperative splenectomy. Now, in all these scenarios, this becomes an important patient where more urgent, emergent and urgent therapy is required. So you have to admit and treat these patients. So this becomes an inpatient as opposed to the outpatient there last time, just giving steroid therapy. This becomes the inpatient. And how you treat these patients? A higher dose of steroid. We like to give this patient platelet transfusion, or else one of the mainstays of therapy is an intravenous immunoglobulin, IVIG, in a dose of 1 gram per kilogram per day. Give it for 2 days. And the platelet rise within 2 days. Within 48 hours, the platelet shoots up, right? Then comes the third group of patients. So first was the patient with no symptoms, with symptoms, a much more serious patient, and a refractory patient. This is a fourth group of patients. Refractory basically means this patient is not showing any more, he's not showing any sign of steroid therapy now. Initially, the patient was responsive to steroid therapy. He's no longer responsive to steroid therapy. So what do you use in these patients? Thrombopoietin receptor antagonist, number one, rituximab, and this is basically a monoclonal antibody indicated when you got a ITP lasting for more than 3 months, or the patient has become corticosteroid dependent or resistant. In either cases, the patient has responded to steroid, and the moment you stop the steroid, the platelet count goes down. So he's a corticosteroid dependent patient. Or resistant, they're using higher and higher dose of steroid, and still the patient does not show any kind of a response. So in these cases, you should not continue with steroid. You should shift to rituximab, and that dose I've written out there, and response rate is 28 to 44% in these patients, which is not a very bad response rate. Other drugs which can be used in these refractory patients could be intravenous Rh negative D immunoglobulin or fostamatinib, which is a spleen tyrosine kinase inhibitor. These are inhibitors, tyrosine kinase inhibitors, tinib, that's why the suffix tinib, and used in patient chronic ITP. And then comes last of all, in refractory patients, what should you do? Surgery. And what surgery are we talking about? Splenectomy. So here the surgeon steps in and he decides that the spleen has to be removed, or the physician decides that the patient now be referred to the surgeon. Why? Because number one, there has been prolonged steroid therapy in toxic doses. Number two, there have been 2 relapses on steroid therapy, or the patient has got persistent thrombocytopenia of more than 10,000, a duration of ITP of more than 9 months, pregnancy in the second trimester, failure of conservative therapy is there, and steroid response predicts good response to surgery. If all these things or any of these things are there, this becomes a prime candidate for splenectomy, who's going to respond to splenectomy. And what should be the method of doing it? It should be laparoscopic splenectomy, which is the gold standard of IT therapy or ITP therapy, and that should be substituted, or that should be in addition to that, you should also carefully search and remove any spleneculi which are accessory spleens, because if you don't do so, then your operation is a waste. Why? Because those remaining spleneculi would take up the function of the spleen and the patient will have a recurrence of ITP. So when you're doing a laparoscopic splenectomy for ITP, it is very, very important that a careful search is to be made. And if you remember the last lecture we talked about, the most common sites we're looking for is number one, the hilum, then you're looking for the ligaments of the spleen, and you're looking at the greater omentum. These are the primary sites where you're looking, or you should be looking for a spleneculi, right? Post surgery, how does the spleen help? It does. Almost 2/3 of the patients are cured, which is a very high figure. 15% improve, but there is a downside to it, and that is in the remainder, it does not have any benefit. What is the complication of going ahead and doing continuing with thrombocytopenia, immune thrombocytopenia, intracranial other major hemorrhages, severe blood loss, adverse effects of steroids, and pneumococcal infection post splenectomy? These are the complications of ITP. Coming to the second group where you may require splenectomy are the hemolytic anemias. How do you classify them? A very simple classification of hemolytic anemias is given out here. Just remember, it's very easy to remember. Number one, you're talking about something wrong inside the RBC. Number two, you're talking about something on the surface of the RBC which is wrong. And then, of course, something which is away from the RBC, but still the spleen is getting affected. So when you talk about the defects in the membrane, we are talking about hereditary spherocytosis or paroxysmal nocturnal hemoglobinuria. If you're talking about the interior, then you talk about enzymatic defects, namely 2. One is the pyruvate kinase, and number 2 is G6PD deficiency, right? And then, of course, you're talking about the hemoglobinopathies, namely thalassemias and sickle cell anemia. Now, if you look at this, we said there's another important condition, and this is a chart which is very important. It tells you where splenectomy would help you, like example, hereditary spherocytosis, elliptocytosis, splenectomy helps you. You have a non-spherocytic hemolytic anemia, only of the pyruvate kinase deficiency type. Remember, not G6PD type, the splenectomy is going to help you. But in hemoglobinopathies, it is plus minus. A thalassemia, sickle cell disease, a splenectomy is not a must. It may or may not help the patient, depends upon specific indications. And then, of course, the autoimmune hemolytic anemia, again splenectomy plus minus. But then most of these hemolytic anemias, see, most of them are responding to a splenectomy. So similar to ITP, where splenectomy forms one of the cornerstones of therapy, especially in refractory patients, or in patients where there are other indications, even hemolytic anemia, splenectomy have got, I would not say a major role to play, but a moderate role to play. If you look at the hemolytic anemias as a whole, the presentation is common to any of these varieties. We talk about any of these varieties, it's common. Either it's presenting as an acute crisis or presents usually as a chronic form in the form of mild anemia, mild intermittent jaundice, which is a hepatic jaundice, gallstones are there, hepatosplenomegaly is there, and chronic leg ulcers. This is the most common presentation, interspersed with acute crisis, and these crises are crises of RBC destruction. And how would they present? Number one, acute non-specific abdominal pain, pyrexia, nausea, vomiting, extreme pallor, and of course fatigue. So this is common to all kinds of hemolytic anemia. All these would have a similar kind of presentation, right? How do you diagnose it? Number one, increase unconjugated bilirubin, absent urine urobilinogen because bilirubin is bound to albumin, increase fecal urobilinogen, reticulocytosis, Coombs test positive, and daily monitoring of increase RBC destruction over the spleen. How do you monitor it? By radioscopic monitoring using 51 chromium radioisotope. So these would label the RBC, and then the activity of the spleen can be seen to be increased manyfold. Why? Because the RBCs are being destroyed inside the spleen. So the hereditary hemolytic anemias we just not talked about. So see, these are the hereditary RBC interior, membrane abnormalities. These are hereditary. They pass on from family to family, one generation to the other generation, and then you go the acquired one. So in the hereditary type, the most important is spherocytosis, autosomal dominant. And what is wrong in spherocytosis is wrong in the membrane. So what is wrong in the membrane? There is a deficient membrane phospholipid, that is spectrin. So the membrane becomes weak, increasingly permeable to sodium. The sodium potassium pump is not enough to push the sodium out. So what happens? That the RBC swells up, and the energy is not available to the sodium pump. And what is the side where the energy is at a premium? It is in the spleen. So in the spleen, the RBC gets even lesser oxygen, so less energy generation, and that is why the RBC destruction and the swelling up would be there more in the spleen. Manifestation, either childhood or late manifestation, acute or chronic, similar to any hemolytic anemia. What helps in diagnosis is the increased RBC fragility test, which normally starts at 0.6% saline or more stronger solutions in a patient of spherocytosis. If you look at the normal RBC fragility, it starts at 0.47%. But here it is starting at a higher 0.6% or more stronger solutions. You would have a RBC fragility test. The rest of the investigations were common to what we just now talked about in the last slide. The treatment is simple, splenectomy, but two things to be remembered. Number one, only after the age of 6 years and before the gallbladder stones have formed. Why? Because if that doesn't occur, then you have to also carry out a cholecystectomy. So 2 points of importance when you're deciding about splenectomy in a spherocytosis. Carry it only after 6 years of age. Why? Because below 6 years, splenectomy always has a increased incidence of complications post splenectomy and before the formation of gallbladder stones, right? GSD is gallbladder stone disease. That is gallbladder stone disease. Okay. Now coming to the second, and that is hereditary elliptocytosis. Similar to spherocytosis, here only the shape is different, and splenectomy is going to help in every symptomatic patient with elliptocytosis. But coming to the non-spherocytic, so these are spherocytic varieties. Now a non-spherocytic variety, and this is I now told you it is basically because something wrong inside the cell, and that is the enzymes. Two enzymes. One is the Embden-Meyerhoff pathway enzyme, that is the PKD deficiency. Seen majority of 90% of cases where you got RBC deficiency. In the rest 10% is G6PD deficiency. But the pyruvate kinase deficiency is the type that is going to respond to your splenectomy, and the spleen will be palpable only in this deficiency. In HMP shunt enzyme deficiency, that is namely glucose 6-phosphate dehydrogenase deficiency, there is no spleen. The splenectomy is not indicated. See, bold. So it is only in pyruvate kinase deficiency type of hereditary non-spherocytic hemolytic anemia that you would be having a benefit of splenectomy. Now coming to I think it's just a repetition of that. Okay, now coming to the third group in the hereditary variety, and that is thalassemias. And thalassemias, we all know, are basically when you have an abnormality in the hemoglobin synthesis, autosomal recessive, and three types: alpha, beta, which is the most common, and gamma type, presenting either as a major thalassemia major or minor, which just tells you whether it's a homozygous presentation, genetic presentation, or heterozygous presentation. Now, we are basically concerned with the homozygous presentation because that is the group of patients where splenectomy may possibly help. And how do they present? Very early in life, first year of life, anemia, mild jaundice, typical facies. I'm not going to go to the details of facies, just read it from pediatric book. Leg ulcers, splenomegaly, and abdominal distension. And the diagnosis is very easily made by doing a hemoglobin electrophoresis, where you find the faulty hemoglobin in major amounts, either alpha, beta, and gamma types. The treatment is very commonly, we know that any kind of thalassemia, you have to keep on pumping blood into this patient, so repeated blood transfusion. But the problem with repeated blood transfusion is simple, and that is in these patients would have a later resistance of uh, effect of the transfusion. Why? Either because there is a development of antibodies or there is hypersplenism. So the moment you push an RBC, within 24 hours, it goes down again. So patient again becomes anemic. You pump in blood, it disappears. Pump in blood, disappears. So these are those patients who become resistant to future transfusions, either because they developed antibodies or they have hypersplenism. Splenectomy is going to help in these patients if their antibodies or very frequent blood transfusions are required. On the other hand, the second hemoglobinopathy is sickle cell disease. This is autosomal recessive. This was basically autosomal recessive, and this is autosomal recessive. Here, the pathophysiology, you find increased amount of HBS type. I'm not going to go in details of what that basically means. Again, it presents in two forms, either the trait, which is usually the symptomatic, asymptomatic, or you can have a sickle cell disease. So you have a sickle cell trait, you have a sickle cell disease. Let's forget the sickle cell trait because that does not give us surgeons any room for any kind of manipulation. We are only concerned with the sickle cell disease. And this sickling phenomena, we all know, increases when there is an increased amount of HbS type of hemoglobin, there's a decreased pH, that means an acidic pH, or there's circulatory stasis. In all these conditions, there is splenic enlargement, and later spleen undergoes infarction, and there can be marked contraction with eventual autosplenectomy, which would be a very, very favorable kind of outcome for this sickle cell disease. But if it doesn't occur, if the autosplenectomy doesn't occur, splenic infarction doesn't occur, then you have to carry out a splenectomy, only required in children with large spleens where increased sequestration of RBC occurs, but it is not indicated in trait. I told you, trait, surgeon, no role. Sickle cell disease, yes. When? Usually children or in those who have got large spleens which are showing signs of increased amount of sickling and destruction. Coming to the third type of hemolytic anemia, where it's going to help you. So we talked about the hereditary two types. One where we talked about what? The RBC membrane. Number two, we talked about the RBC interior, that's the enzymes. And number three, we talked about the hemoglobinopathy. Three, hereditary hemolytic anemia. Now coming to the acquired hemolytic anemia, and these acquired hemolytic anemias could either be immune or non-immune, right? The immune is what we call it as IAHA. The non-immune variety is either because of drug. This is the non-immune, this is the acquired variety. See, hypersplenism, this is the immune variety, mechanical trauma, infection, toxin, etc., etc. So these are all non-immune. So you can have chemicals, you can have infections, you can have associated other disease like SLE. So these are non-immune. But the immune variety or IAHA or the immune acquired hemolytic anemia, immune acquired hemolytic anemia, there's an unknown reason. But the second method of defining this IAHA is basically based on the warm and cold antibody. Usually acute, self-limiting, so treatment may not be required in this condition. See, acute, self-limiting. Signs, symptoms, same for any hemolytic anemia. Usually females more than 50 years of age. Splenomegaly is in 20%. And investigation is just like for hemolytic anemia. Coombs test is positive. The treatment is usually conservative. Splenectomy, 80% patient response. So if it is required, if it's required indication splenectomy, 80% of these patients are going to respond to your splenectomy, right? Now, this is acquired types. You have the primary. So this was the immune and or non-immune. Now let's talk about the immune variety in just very short, and that is warm and cold antibody. What do we mean when we say warm antibody and cold antibody? We're talking about antibody inside the cell working either at 37 degrees or below 37 degrees, which is your core body temperature. So if you've got a cold antibody, it will be working at below 37 degrees. The warm antibody will be working more than 37 degrees. And when I talk about the autoimmune, so see, two, non-immune and immune. So when you talk about the immune autoimmune variety, it's again two types, one primary and number two secondary, right? Now symptoms are similar. Treatment of any autoimmune HA has to be steroid, immunosuppressive therapy, or blood transfusion, and then of course splenectomy. What is a cold antibody and warm antibody? Just a slide to help you to just remember what basically these are. But this is a slide which tells you what's a direct and indirect Coombs test is. Now, direct Coombs test, just 2 or 3 lines about it. This you would be knowing from knowledge of pathology. I'm very sure about that. But a direct Coombs test, we know it detects those antibodies already fixed. See, antibody fixed to the RBC. And indirect is trying to decide on the level of antibodies which have still not been fixed. So you have to fix it. So in the indirect, what do? You push in some foreign RBC, which are known as test RBC, so that now these immunoglobulins will combine or coat the RBC. So the only difference between direct Coombs and indirect Coombs is either fixed antibody or unfixed antibody. And if it is an unfixed antibody, it has to be treated with test RBCs taken from some source. It could be animal source or otherwise added. So now the hemoglobin is fixed, and then subsequent the reaction becomes the same. You're looking for agglutination. So in a direct, it is just simple agglutination. In an indirect, you have to add RBCs and then look for the agglutination. So this is just to make you understand. I found it to be useful method of remembering what direct and indirect Coombs test is all about. Porphyria is the other condition where splenectomy may help. Porphyria, we all know, is a disorder of hemoglobin catabolism. So now we talk about hemoglobinopathies where the formation of hemoglobin was defective. Now we talk about defective catabolism of hemoglobin. And here we talk about increased excretion of coproporphyrin and uroporphyrin in urine, so that urine looks orange. When you first of all pass urine, it is orange. You leave it in contact with the air for about 1 to 2 hours, and it becomes what? It becomes poured wine. That's why the typical of porphyria is a poured wine urine on standing in contact with air for 1 to 2 hours. Abdominal crisis of severe pain, constipation, precipitated by barbiturates is a very, very characteristic feature in young children or young females, which often tends to get missed out. You don't diagnose porphyria because there is no specific indication for diagnosing it. So it becomes more of a diagnosis of exclusion rather than a primary diagnosis. Anemia photosensitivity is very much there, and unfortunately most of these patients may be recognized very late when they develop neurological and mental symptoms. Two types, erythropoietic and hepatic type of porphyria. That basically means the catabolism is either as a primary followed with the RBC itself or a hepatic type. Now erythropoietic may rarely require splenectomy, and in hepatic type there is no role of splenectomy. So in porphyria, the role of splenectomy is very you rarely require it, and that also when you've got a erythropoietic type of porphyria, right? Just a few ancillary splenic conditions. Splenic artery aneurysm, less than 1% of postmortem patients, more common in females. Causes are very simple. Either there has been a septic problem in the abdomen, or most commonly secondary to pancreatic necrosis following acute pancreatitis. Or it could be as a part and parcel of an old age disease where the arteries have undergone arteriosclerosis, they become weakened, and they develop an aneurysm. The aneurysm in the splenic artery can either present as a solitary aneurysm or multiple aneurysm in 1/4 of the patients. The diagnosis is very commonly asymptomatic and incidental. So that means an accidental finding on an abdominal scan done for some other reason. So it is an incidental finding on a routine skygram for some other condition. That means they are mostly asymptomatic. They may become symptomatic when they rupture. And when they rupture, the symptomatology is similar to a splenic rupture, and 50% of the rupture in patients occurs below 45 years of age. That basically means it is not old age arteriosclerosis, because that's going to occur only after 50 years of age. 25% pregnant females, and that also in the third trimester, right? The diagnosis is very easily made based on a routine ultrasound, or you go higher up, do a CT, or you do a MRA, that is the MRI angiography, right? Magnetic resonant angiogram, or you can do a celiac axis angiogram. So either of these can help you to diagnose. Now, how do you manage this patient? You try to go in for minimal invasive, do nothing, observe. If at all you want to do something, just embolize or pass in an endovascular stenting of the artery. So stenting of the artery is going to relieve pressure over the sac of the aneurysm. Or if you do embolization, it's going to block the artery. Either way, you're going to treat it. But if you don't have any recourse to using these minimal invasive methods, then go ahead and do a ligation or with or without splenectomy in these patients. Coming to the second vessel, that is the splenic vein, that can undergo thrombosis. That is the most common pathology in these patients. And again, see, it is a pancreatic pathology which is at work. Splenic artery, pancreatic pathology, primarily. Here also pancreatic pathology. And that the reason is simple. The anatomy is simple. One is following the superior margin of the pancreas. The other is lying just behind the pancreas. Splenic vein is lying behind the pancreas, the upper part, right? So any kind of pancreatic pathology, especially inflammatory pathology, where there's a lot of pancreatic destruction, cell destruction, is going to damage your artery, nabble, and vein. So here also splenic vein thrombosis, the most common is hepatic pathology, history of pancreatitis, usually seen in more than 50% of patients. Cirrhosis formation may be there, chronic pancreatitis in 40% patients, or carcinoma pancreas. So any kind of pancreatic pathology may damage your splenic artery and vein. In the vein in the form of thrombosis, in the artery in the form of either aneurysm or rupture. The other causes of splenic vein thrombosis could be penetrating gastric ulcer. Penetrating basically means a posterior wall gastric ulcer which is penetrating posteriorly. Or you can have retroperitoneal fibrosis or myeloproliferative disorders. The pathophysiology is simple. Your splenic vein gets blocked. What happens now? Reversal of flow. Where? What is draining into the splenic vein? The splenic vessel. Agreed. Doesn't make much of a difference. But remember the short gastric up and the gastroflowic down. So these, if they get a reversal of flow, are going to lead to what? Development of gastric varices. But one thing is very important, esophageal varices do not develop. So on a OGD, if you find gastric varices without esophageal varices, you have to be on the lookout for some kind of a splenic vein pathology. The symptoms are non-specific, abdominal pain, the patient has hematemesis. Why hematemesis? Rupture of the gastric varices. That is the variceal bleeding. Patient may have splenomegaly, ascites rarely. The diagnosis, as said earlier, a Doppler's ultrasound, celiac angiogram, CT-MRI or MRA, and additionally, OGD may help you with the diagnosis of gastric varices, and a thrombocytopenia may help you. So these are basically additive investigations. The diagnostic investigations are these three, right? The treatment simple. Again, here also it is splenic. Sorry, this should not be artery embolization. Why should you do a splenic artery embolization? I'm sorry, it is splenic artery embolization. Why do you want to do it? Because you want, remember, vein is blocked, artery keeping the arterial blood is still pumping in. So that is going to lead to aggravation of the varices. So go ahead and do a splenic artery embolization so that the gastric gastrocoploic and the short gastric vessels are tackled. You can do a percutaneous recanalization of the splenic vein so that the blood outflow from the spleen restarts. So either doing a recanalization of the splenic vein or splenic artery embolization, or else go ahead and do a splenic abscess, uncommon but potentially life-threatening. That is why it is important. Mortality rate, see, 15-20% in a solitary abscess. That's a very high mortality rate. And 80% in multiple or immunocompromised patient. 80% mortality. I am an immunocompromised patient, I am HIV positive, and I have splenic abscess. My chances of surviving are only 20%. That's a very high mortality rate. The cause, what leads to splenic abscess formation? Either about septicemia somewhere in the body. So hematogenous spread to the spleen. Number two, a local spread from adjacent organ. Like example, let's say a kidney abscess, or let's say a colonic perforation, colonic diverticulitis, leading to of the splenic flexure, leading to what? A splenic abscess. Second use splenic vein thrombosis, splenic infarct in the splenic cell anemia, or a sickle cell anemia, or immunosuppressive patients. In all these cases, especially immunosuppressive where the fungal infection is more common, candidiasis, but otherwise all these are conditions where the chance of having splenic abscess is much more. What are the organisms? Gram-positive cocci, primarily staph, strepto, entero, and gram-negative enterococci, which are important, and others like example mycobacterium and fungal. Signs, symptoms, non-specific. You'll find features of infection in the body. You try to localize where is the infection. You may get a left hypochondric pain, or you can get left pleuritic pain, and you may be able to palpate the spleen. So that gives you an idea that probably you're dealing with a splenic abscess. They're very severe pain on respiration in these patients in the initial stages. Why? Because of irritation and inflammation of the diaphragmatic pleura. The diagnosis is very simple. Gold standard CT. You can do an ultrasound, or you can do ultrasound guided aspiration. You'll be able to aspirate pus from the spleen. The treatment, if it is unilocular, do a guided aspiration. That may suffice. If it doesn't, go ahead and do a splenectomy. Multilocular splenectomy is the rule, but easier said than done. Remember, doing a splenectomy, splenic abscess is fraught with a lot of complications and danger. Why? Because of severe adhesions. And that is why more often than not, try not to do a splenectomy in a patient with splenic abscess. Try to treat this patient conservatively rather than going and do a splenectomy, because splenectomy is a major technical exercise in a patient with splenic abscess. Splenic cysts most commonly are parasitic 80%, non-parasitic 20%. And among the parasitic, the most common is hydrated. When you talk about the non-parasitic 20%, out of these, 10% are true. Pseudocysts, which is pancreatic pseudocysts, 80%, and rest of them are post-traumatic or neoplastic. So this is the group for the 20% or 10-20% non-parasitic. They are subdivided in such a way. Now, in a true cyst, which is a dermoid of the spleen or epidermoid or epithelial cyst of the spleen, you would have a raised CA19-9 and CEA, which is contrary to the belief that these are markers which are tumor markers. That means they should be raised in a patient who's got malignancy. But here, remember, it's a benign condition. A true non-parasitic cyst is a benign condition, and still you find a raised CA level and CA level, right? They present as asymptomatic lump, or rarely there will be complication in the form of hemorrhage, infection, or rupture. Then they become symptomatic. The treatment is splenectomy in all cases. Remember that. If the patient has got uncomplicated, don't do anything. It's large size, you have to do a splenectomy, complicated splenectomy. So in majority of cases of splenic cysts, you may be requiring a splenectomy. And that is the last, I think, the splenic tumors. Just very short, benign tumors are, because splenic tumors are not very common entities. Benigns are the hemangiomas, splenectomy will help you. Lymphangioma doesn't help you. Myelofibrosis, gross splenomegaly with infarcts or proliferation, splenectomy will help, right? Malignant, primary sarcomas, lymphomas, or you can have secondaries which are rare. The diagnosis is done basically on an ultrasound or CT guided splenic biopsy, or you can do a diagnostic laparoscopy and take a biopsy. But taking biopsy from the spleen is fraught with danger and a very dangerous exercise. You have to be very, very careful when you're doing a splenic biopsy because of the high vascularity or the vascular nature of the spleen. The chance of having torrential bleed is very, very common. Coming to the last part, and that is OPSS. It needs to be mentioned: overwhelming post-splenectomy sepsis syndrome or overwhelming post-splenectomy infection, synonymous. And why do we need to do that? We need to know this because most common and most mortal complication after splenectomy is OPSS or OPSI. Let's look at the incidence. Post-splenectomy time frame. First, time frame is very important. Now, today I have splenectomy, and you told this patient you may get infection anytime. Now, the obvious next question is, up to what time am I liable to get this kind of infection? But see, up to 20 years post splenectomy. That means if today you have a splenectomy, up to 20 years, you are at increased susceptibility to get an OPSI or OPSS. But the greatest risk is within the first 2 to 3 years, and 1/3 of the patient within the first 10 years. But nevertheless can occur any time up to 20 years. And when is it most common? After splenectomy in patients who are less than 5 years. Remember, we said sickle cell anemia, prefer not to do it below 6 years. Why? More complications. Splenectomy done for hematological condition, like example, spherocytosis, thrombocytopenia purpura, sickle cell disease. These are the patients who are increasingly susceptible for OPSI. Asplenic patients more susceptible to OPSI. The mortality rate is very high, 10%, and maximum in the first 48 hours following your spleen removal. What is the bacteriology? What causes this infection? Most commonly encapsulated organisms, and among them, the most common is the Streptococcus pneumoniae, 50 to 90%. Encapsulated, so it's particularly resistant after splenectomy, right? Meningococcal influenza, Streptococcal group A, and E. coli are the other organisms identified in OPSI. Clinical presentation, onset is very rapid, like a flu-like prodrome. The patient just feels upper respiratory infection, but within 24 to 48 hours, he goes into shock. You can't understand what that's happened. Then remember, this patient had a splenectomy. So that is basically the progression of OPSI or OPSS from a non-specific flu-like prodrome to a very rapid development of bacteremic septic shock. You have hypotension, anuria, multiple organ dysfunction and failure, and ultimately leading to disseminated intravascular coagulation and bilateral adrenal hemorrhage presenting as Waterhouse-Friderichsen syndrome. And these are the patients who will develop intractable or irreversible septic shock. The treatment, you have to give this patient, the moment you recognize this condition, put this patient on third generation, fourth generation of cephalosporins, that is cefotoxime or ceftriaxone. The doses we have written down. Resistant pneumococci who don't respond to these cephalosporins, you have to take recourse to vancomycin. Prevention is always better than cure, and that is also true when you talk about OPSS or OPSI. So prevention in the form of when you're planning elective splenectomy in a particular patient, so what should be the preventive aspect? Number one, if it is a child less than 5 years who's destined to undergo splenectomy, put this patient on penicillin daily for about 10 years of age. Older children, penicillin up to 16 years. See this, daily penicillin, 10 years, a formidable task, even for the patient and for the doctor. Not very attainable, very easily attainable, not very easily attainable. You ask somebody to take a particular drug for the next 10 years of his life, he'll never do it. Nobody does it 100% of the time. So that becomes a very problematic kind of a preventive aspect. So what is better? What is better is a vaccination against influenza, pneumococcus, and meningococcus. A prior vaccination should always be given in these patients. Prophylactic oral penicillins, erythromycin, amoxicillin would be better serving the patient rather than giving these patients drugs parenteral, right? Wandering spleen is a term very commonly used to describe a uncommon condition, commonly used term for uncommon condition, rather rare condition. And what is happening in this? Why do we call the spleen wandering? Because now got a pedicle. It's got a pedicle. Normally, is the spleen a pedicle? It has a pedicle, but it's a fixed structure. But now it has got a long pedicle. And how does this pedicle develop? Either there's a non-fusion of the dorsal mesogastrium to parietal peritoneum. You remember the first lecture on the embryology, we said that the spleen is on the left side of the mesogastrium, and that mesogastrium is going posteriorly and going to fix itself to the peritoneum overlying the kidney. So that forms the lino-renal ligament. Now, in a pedicle spleen, that fusion is missing. So now the spleen has got a large splenic hilum and a large splenic pedicle. That's one. Number two, multiparous females, because hormonal changes have loosened up all the ligament. So in these two scenarios, you can have a patient with a long pedicled spleen, which is known as the wandering spleen, most commonly seen in children and females in the age group of 20 to 40 years of age. Signs and symptoms are very typical, and that is because the spleen is moving. It is causing traction over the vessels, leading to what? Venous congestion. And that is what leads to intermittent or continuous severe pain. If the pedicle undergoes torsion, it becomes continuous severe pain. And you can find a lump anywhere in the body. You try to palpate the spleen the left side. Instead, you find a lump, a vague lump, less in the periumbilical area. You don't diagnose it as a spleen. A periumbilical lump is more likely to be a mesenteric lump, right? But then you have to remember that this could be one of the rarer diagnoses. The diagnosis is very easily made on a CT with IV contrast, and the treatment is simple. Either you fix the spleen or remove it. As simple as that. But remember, splenectomy should not be undertaken as a very light operation, in the sense that the after effects of splenectomy are very, very morbid and mortal, right? The post-splenectomy column, why mortal and morbid? I just now told you, short-term post-splenectomy, especially when you have got patients where you removed a very large spleen of more than 90 centimeter length. That is what? Massive splenomegaly. Remember? So this patient can have a secondary or reactionary hemorrhage, pulmonary left basal pneumonia effusions, pancreatic leaks because you managed to damage the tail of the pancreas at the hilum, gastric fistula, you managed to damage the short gastric vessel while doing splenectomy, or you can have a splenic thrombosis in the form of splenic, portal, or mesenteric vein thrombosis. Long-term complication, OPSI is the most notorious and most problematic. You can have deep vein thrombosis, you can have thrombocytosis. Why thrombocytosis? Because spleen was regulating the level of platelets. Now spleen gone, the platelets suddenly shoot up. So thrombocytosis, and this may require treatment separately. Or you can have a splenic thrombosis, we just talked about that, and myocardial infarction. These are post-splenectomy complications. I think we finished spleen, and that should be the end of spleen. Thank you for your time. And more educational videos and lectures, we all talked about that. So if you have any questions, you know where to reach me. Thank you for your time.